So thank you, ma'am, and thank you, sir. It is really a very great opportunity for me to be in front of you. You see, every year we come here to learn and to grow. And I must respect my teachers who are sitting here. I have learned so many things from you, and we are trying. Professor Nuzhat is here. We are trying our level best uh, to update this knowledge and to help our patients in our country. Today, my topic is anti-VEGF in ROP management, comparison between global trials and our experience. You see, we know that ROP is an interplay of growth factors, not only vascular endothelial growth factor, there are insulin-like growth factor 1 and transforming growth factor beta, but we are more concerned about the anti-vascular endothelial growth factor for our patients. Till now, laser is the gold standard, and still I believe that laser is the gold standard for ROP management, but there are some demerits. Laser alone for severe posterior APROP, it is challenging if the pupil is not dilating, and there are also field defect, high refractive error, and late onset angle closure glaucoma, and there are other changes like cataract and anterior posterior synechiae. This is a patient, you see, we did laser around 11 years back, and now the patient is 11 years and minus 11 diopter in both eyes, but vision is 6/9, but pale disc, and the retina is so much sclerosed vessels and others. So, what are the advantages and reasons for popularity of anti-VEGF for ROP? It is brief, easy, less stressful, quick and dramatic effect you can find, and less refractive error and better field you can find with injection anti-VEGF, and there is no retinal ablation and can be done even at NICU. This is the publication which helped us to go for injection anti-VEGF in our retina patients that beat ROP, which showed the pathway, and it told that intravitreal bevacizumab monotherapy as compared with conventional laser therapy in infants with a stage 3 plus retinopathy of prematurity showed a significant benefit for zone 1 but not zone 2 disease. But later on, we found that some indications like non-dilating people and disease is too posterior with vitreous hemorrhage, and baby is too sick to touch, or relatively sicker babies with inadequate neonatal support to tackle in emergencies, we have to go for injection anti-VEGF. This is an hypothesis given by Dr. Tapas and Dr. Subhadra that what happens after putting the injection. In the phase 1, within 1 week, you can find that the stage of rapid whitening, and then up to 11 weeks, slow vascular development occurs due to new VEGF formation, and up to 16 weeks, a ridge like classical ROP appears. This may regress completely, or it can go to the rebound stage, and it depends on the postmenstrual age and unknown factors. This is the publication of Dr. Subhadra and others, and they showed that if you put injection at first and then do the laser, the combined therapy was successful for ROP management, but before putting the laser, you have to put injection, then the results will be better. Now it came that in 2019, we all know about Rainbow study. It was a randomized open label superiority trial. There were 87 neonatal centers in 26 countries. It included all zone 1, stage 1 plus, 2 plus, 3 or 3 plus babies, and zone 2 stage 3 plus, and also APROP babies. They followed the patients at least for 24 weeks. What they found that they had 3 arms, 0.2 milligram ranibizumab, 0.1 milligram ranibizumab, and laser. The success rate was 80% in 0.2 milligram, 75% in 0.1 milligram, and 66% in laser. And the odds ratio was around 2 with that is ranibizumab 0.2 milligram with laser. This is another slide that you see the retreatment needed in 0.2 milligram, 74 out of 74, 22 babies, and 12 was done injection, 11 was done laser. In 0.1 milligram group, the 22 babies needed that is retreatment, and 12 was done injection, 10 was done laser, and in laser group, only 14 needed retreatment, 13 was done injection, and 1 was repeat laser. So summary of rainbow study was ranibizumab 0.2 milligram was as effective and safe in the treatment of active ROP as laser therapy, and it might be superior and was associated with better short-term ocular outcome. After 2 years, there is another rainbow extension study which showed that it is a 5 years study, but the 2 years data they have published in 2021. The primary outcome was the absence of structural ocular abnormality. Secondary outcome was vision related quality of life, development, motor function, and health status. And investigator determined ocular and non-ocular serious and other adverse events. It showed that the infections and others was much less in ranibizumab 0.2 gram and also in 0.1 milligram stages. And CNS disorders, it was also not present in all the 3 groups. And here that is refractive error was only 5% in ranibizumab 0.2 milligram group and 88% in that is 0.1 milligram, and with laser it was 20% myopic patients. But the children's visual function questionnaire, which was done by the parents, you see there was not much less difference between the 3 groups, though it was not statistically significant, but the 0.2 milligram group showed better result. So in conclusion of rainbow extension study, at 2 years they told that no effects of ranibizumab detected on neurodevelopment, growth, blood pressure or respiratory symptoms, and vision related quality of life ratings more optimal following ranibizumab 0.2 milligram. No late ocular complications affecting vision was also seen in this study. Then another rainbow study, that is time course of retinopathy of prematurity, regression and reactivation. And regression with 0.2 milligram was done in 4 days with plus disease, stage 3 ROP in 8 days, and APROP in 7 days. And you see with laser it was 16, 16, and 22, which was clinically and statistically significant in between these 2 groups. And if it is reactivation, that is if the patient needed additional treatment, it was not very much different in the two groups, that is 0.2 milligram and 0.1 milligram, but you see there was much less retreatment reactivation in laser group. So in conclusion, they told that intravitreal 0.2 milligram or 0.1 milligram ranibizumab induced a faster regression of plus disease, stage 3 ROP and APROP, but ranibizumab was associated with fewer additional treatment. This is another analysis of 40 articles published in ophthalmology. There 15 RCTs, 13 citations, 6 was level 2 evidence, and 7 articles on level 3 evidence. They also commented that intravitreal anti-VEGF therapy as effective as laser photocoagulation for achieving regression of acute ROP. The practice patterns and outcomes of intravitreal anti-VEGF in USA and non-USA countries, there was 23 sites, 16 was from US and 7 was from non-US. They showed that in bevacizumab, they used 71% cases, and all other parameters are very similar like us. And you see a retreatment needed in 36% of the babies. Out of this 36, laser was done in that is around 80% babies, anti-VEGF in 11%, and anti-VEGF plus laser in 10% babies. And you see, most importantly, they did in stage 3 ROP, the injection was given. And you see, bevacizumab was 72% cases, and there was not so much complication, and endophthalmitis was 0. But you see that the patients, they did the injection in US and non-US babies, the injection was given in the neonatal intensive care unit in 80% of cases. But we are putting injection in the OP in our OR. This is another study in that is the Royal College of Ophthalmologists. They told that they evaluated all the articles, and they told that you see injection bevacizumab or ranibizumab both are superior to laser, but they asked to do the laser in zone 2 diseases at first, and if it is zone 1, you can do injection, you put injection Avastin or Lucentis, whatever you prefer. There is another comparison, and it also told the incidence of disease relapse was higher in eyes with received ranibizumab. This is another article. In care ROP group, they told also that neurodevelopmental and functional ocular outcome 1 and 2 years after treatment with ranibizumab are reassuring regarding long-term safety. This is an LVPI experience I took from Dr. Tapus Padi, that 111 babies or eyes, anti-VEGF was done in 31, anti-VEGF plus laser in 54, and anti-VEGF plus laser plus surgery in 10 babies in 18 eyes, and anti-VEGF plus surgery in 1 baby in 2 eyes. Now I want to share my experience and our experience, that is me and Professor Nuzhat, what we are doing in our university. This is a presentation we gave in APAO in 2020 from 2012 to 2019. Out of 63 babies, we followed only 12 babies with injection. Otherwise, 51 babies we did injection plus laser in APROP cases. This is the total in 2021. Out of 364 babies, we did injection in 10, laser in 29, and injection plus laser in 10. And in 2022, out of 869, we did this type of, that is, LIO was less than injection. Injection was increasing. This is 1 month after injection. This is injection and laser. What I want to tell, that probably our trend is going to less injection much more in 2022 than 2021. Probably this is not correct, but not correct approach for us. That you see, the ladder is going towards the injection right now. So in conclusion, what I want to tell, that intravitreal anti-VEGF should be used as the first line treatment for zone 1 ROP, while laser therapy should be the mainstay of zone 2 ROP, owing to the different pathogenic mechanism. In patients with recurrence after initial anti-VEGF injection, that given ranibizumab may opt to repeat the injection, while the given bevacizumab should consider supplement laser ablative treatment. Thank you, ladies and gentlemen.